Welcome to this explainer, everyone. Today, we're going to systematically break down the advanced clinical mechanisms, the strict classifications, and the absolute lethal extremes of hypothyroidism. We are taking this way beyond a basic overview into a PhD-level masterclass. We'll be using precise terminology to map out the clear, logical flow of this disease state, and I promise you, we are not going to oversimplify anything.
Here's our roadmap for today. We'll move swiftly through Section 1, Classification and Pathogenic Framework, Section 2, Etiology and Histological Hallmarks, Section 3, Clinical Phenotypes and Presentation, Section 4, Diagnostics and Immunological Profiling, Section 5, Pharmacotherapy and Treatment Thresholds, and we'll wrap up with Section 6, Complications and Endocrine Emergencies.
All right, let's jump right into Section 1, Classification and Pathogenic Framework, specifically focusing on the four-class system.
So before we even think about looking at a patient's symptoms, we have to ground ourselves in the strict four-part pathogenic framework. It literally dictates every downstream clinical decision you're going to make. Let's break down the four classes. First, congenital hypothyroidism is largely driven by thyroid hormone dysgenesis. You'll spot this via classic neonatal clues like an open posterior fontanelle and prolonged jaundice. Next is consumptive hypothyroidism, which is a really fascinating mechanistic detour. It's actually driven by hemangiomas that express massive amounts of the deiodinase 3 enzyme, which just excessively chews up and breaks down thyroid hormone. Then we have secondary failure, which is typically a pituitary mass effect. Lymphocytic hypophysitis is a prime example here. And finally, primary hypothyroidism. This is what clinicians usually mean when they just say hypothyroidism, and it's overwhelmingly dominated by the autoimmune destruction we see in Hashimoto's thyroiditis.
Now, when we look at drug-induced causes, a really fascinating dichotomy emerges. Take lithium, for example, a classic exam association. It directly blocks the synthesis and release of thyroid hormone. But look at interferon alpha. It causes irreversible thyroid destruction. This is an absolutely critical distinction from its much more commonly known, highly reversible flu-like adverse effect. And then there's amiodarone. This drug is a unique dual threat. Its exceptionally high iodine content can trigger both thyrotoxicosis and hypothyroidism, completely depending on the patient's underlying physiology.
Moving right along to Section 2, Etiology and Histological Hallmarks. Let's zoom in on cellular-level destruction.
You absolutely must uncompromisingly lock these histological hallmarks into your brain. Driven primarily by T cells, we see dense lymphocytic infiltration in the formation of germinal centers. Pay very special attention to oxophilic metaplasia and Hürthle cell change. They feature that highly distinctive eosinophilic cytoplasm. We also see follicular atrophy with a complete absence of colloid alongside mild fibrosis. Crucially, Hashimoto's carries a theoretical premalignant association. And I'm not just talking about papillary carcinoma. The real, exam-relevant trap is MALT-type extranodal marginal zone lymphoma. Underlying all of this microscopic chaos is a shared autoimmune genetic background linked to HLA-DR3, DR4, and DR5, as well as specific CTLA4 and PTPN22 polymorphisms. Listen closely because there is a literal life-or-death clinical trap right here that you have to recognize. Hashimoto's is heavily linked to autoimmune polyendocrine syndromes, particularly APS2. If you blindly initiate levothyroxine in a patient with combined endocrine autoimmunity without prior cortisol replacement, the suddenly restored metabolic rate is going to drastically increase their cortisol catabolism. What does that do? It unmasks their underlying Addison's disease, precipitating profound, shock-inducing adrenal failure. The patient is not going to get better, they will rapidly crash.
Okay, Section 3, Clinical Phenotypes and Presentation. Let's unpack the two pathways of pathology. So, when we look at the pathology, we're really dealing with two completely distinct clinical buckets. In the first bucket, we have generalized slowing resulting from a significantly reduced basal metabolic rate. This is what causes that classic fatigue, the visibly slow gait, delayed relaxation of the ankle jerk reflex, and profound bradycardia. But in the second bucket, we have a mechanism that is specific only to primary disease, TSH-driven puffiness. Because TSH levels are massively elevated in primary failure, it stimulates fibroblasts to pump out matrix glycosaminoglycans. These molecules literally trap water in the tissues, leading to macroglossia, periorbital edema, and classic non-pitting edema. Remember, you are simply not going to see this glycosaminoglycan accumulation in secondary hypothyroidism, because the TSH isn't elevated in those cases.
To anchor this clinically, there's a brilliant, powerful heuristic regarding carpal tunnel syndrome that you need to commit to memory right now for rapid pattern recognition on the wards. It's a striking diagnostic shortcut. If you see carpal tunnel syndrome in a female, think hypothyroidism until proven otherwise. If you see carpal tunnel syndrome in a male, think amyloidosis until proven otherwise.
Furthermore, we really need to completely throw out that narrow classic textbook patient stereotype. Younger women, specifically age 17 to 25, often present first with profuse hair loss, severe dry skin, and menstrual irregularity, way before they show marked metabolic slowing. That profound slowing of gait and speech, that's actually much more typical of older women. Now, as the disease advances into late, severe phenotypes, we start seeing incredibly dangerous complications: obstructive sleep apnea driven by that macroglossia, and severe serosal fluid accumulations like pleural and pericardial effusions. In fact, if you see a low-voltage ECG at the bedside, that is a massive clue pointing directly to a pericardial effusion in these patients.
Next up is Section 4, Diagnostics and Immunological Profiling. Let's figure out exactly how to distinguish transient flare-ups from lifelong conditions.
When it comes right down to it, the central management question is prognosis, right? Are they stuck with this forever? To determine this, we rely heavily on 3 antibodies. The TPO antibody is by far our most powerful and practical tool. It's present in a staggering 90 to 100% of Hashimoto cases. Thyroglobulin antibodies follow closely behind, showing up in 80 to 90%. A positive result on any of these basically dictates that the patient is facing lifelong autoimmune disease, permanent levothyroxine treatment, and indefinite complication monitoring. Conversely, if those antibodies are negative, it strongly suggests a transient state, maybe post-viral or even post-vaccine, where careful, watchful observation is the appropriate path forward.
We also need to be able to instantly differentiate our thyroid function test patterns. Primary disease presents with a high TSH, which is basically the pituitary screaming at a failing thyroid, coupled with a low free T4. This is fundamentally distinct from the exceedingly rare TSH-secreting adenoma, whereas central tumor is actively driving up both a high TSH and a high free T4.
All right, Section 5, Pharmacotherapy and Treatment Thresholds. We're diving into the exacting protocols for levothyroxine.
Now, if you see a TSH over 10, that's easy. It always demands treatment, regardless of the scenario. But what about that tricky subclinical gray zone with a TSH between 5 and 10? Treatment here is an absolute necessity if the patient is pregnant, if they have a strong family history, if they are TPO positive, or if they have significant classic symptoms. However, if the patient only has vague symptoms and they are TPO negative, we actually default to observation, because as we discussed, this is highly likely to just be a transient inflammatory state.
Here's the thing about prescribing levothyroxine. How the patient takes it is just as important as the dose you prescribe. These 4 sequential steps, they are non-negotiable. The medication must be taken on a completely empty stomach. It needs to be administered strictly in the early morning, let's say between 7 and 7:30 a.m. It must be swallowed with exactly 1 glass of water, and finally, there is a mandatory 30-minute fast before consuming breakfast. Enforcing these exact steps prevents the single most common cause of treatment failure, patient noncompliance, leading to wildly variable absorption.
Diving deeper into the pharmacology, our standard weight-based dosing is roughly 1.6 to 1.8 micrograms per kilogram per day. But listen carefully, we must implement a vital geriatric modification here. For patients over 60, you start at just 25 micrograms. Why? To avoid precipitating fatal cardiotoxicity. We also have to ruthlessly avoid concurrent use of chemical absorption inhibitors, things like ferrous sulfates, calcium carbonate, aluminum hydroxide, and sucralfate. Finally, monitoring this requires clinical patience. You recheck TSH, FT3, and FT4 exactly 12 weeks post-initiation, and then you titrate in very conservative 25 microgram increments toward a target TSH of about 5.
And that brings us to our final section, Section 6, Complications and Endocrine Emergencies. Let's cover myxedema coma and SREAT.
Myxedema coma. This is the absolute lethal extreme, the consequence of complete metabolic collapse. The defining feature you're looking for is a decreased level of consciousness and potentially seizures. Clinically, you need to watch for the triad of hypoventilation, hypoglycemia, and hyponatremia. Their vitals will show profound hypothermia and bradycardia. And remember our earlier cardiac clue? You will absolutely see low-voltage ECG complexes here caused by massive pericardial fluid accumulation. The classic bedside vignette you'll encounter is an obese patient with altered consciousness, and it's almost always triggered by an underlying infection combined with a history of them simply missing their levothyroxine tablets.
The truly horrifying reality of myxedema coma is a mortality rate that sits stubbornly at 40% or even higher. The emergency protocol demands immediate IV levothyroxine, alongside 100 milligrams of IV hydrocortisone to prevent unmasking that coexisting adrenal crisis we talked about earlier. But here is the massive practical barrier.
IV levothyroxine is effectively an unavailable orphan drug in many facilities. This forces desperate bedside improvisations, like crushing oral tablets into a nasogastric tube, a maneuver that unfortunately often fails to save the patient.
For our final topic, we need a complete paradigm shift. We have to completely redefine what we used to call Hashimoto's encephalopathy as SREAT, steroid-responsive encephalopathy associated with autoimmune thyroid illness. This isn't just severe hypothyroidism, this is an autoimmune vasculitis of the brain. It is completely distinct from the normal metabolic slowing of hypothyroidism, and vitally, it is entirely unrelated to the patient's actual thyroid hormone levels. Because it's a vasculitis, S-trait often occurs in perfectly euthyroid patients. It's totally driven by high antibody titers, specifically including anti-enolase antibodies, and it has a genetic link to HLA-B8. The presentation is frighteningly neurologic and psychiatric. We're talking slowly progressive cognitive decline, stroke-like episodes, myoclonus, and subacute confusion. The absolutely critical action here is immediate recognition. Why? Because as the name explicitly implies, it is exquisitely responsive to steroids if you catch it in time.
So, as we wrap up this explainer, I really want to leave you with a provocative thought to chew on. If a condition like SREAT can cause severe stroke-like encephalopathy completely independent of thyroid hormone levels, driven entirely by cross-reacting autoantibodies, what other undiscovered autoimmune vasculitis are currently out there, just hiding behind common, misunderstood endocrine labels? Keep that in mind the next time you review a complex patient chart. Thanks so much for joining us for this masterclass.